Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Joining me today is Dr. Katherine Elkington, professor of medical psychology in psychiatry at Columbia University and a research scientist at the New York State Psychiatric Institute. Dr. Elkington also serves as the director of the Center for Behavioral Health and Youth Justice within the Division of Child and Adolescent Psychiatry, co-director of Grand Rounds for the Department of Psychiatry, member of the Board of Directors of the Research Foundation of Mental Hygiene, and as training faculty on numerous T32 postdoctoral fellowship programs through Columbia University and NYSPI. Kate is also a licensed clinical psychologist. Kate, hello, welcome.
Hello. Thank you. Thank you for having me.
I said before you came on, I could have easily turned this into a soliloquy. There's so many things you've done and do. So if I've missed anything important, and I'm sure I have, please let us know.
No, I think you captured most of it. Yep.
Okay. Again, you're being modest because we can go on pretty much indefinitely. Anyway, thanks. Thanks so much for joining me. I really do appreciate it. So you're up in New York right now, I'm assuming, yes?
That's right. Yeah.
Used to be my stomping grounds until about, 25 years ago. So how's the weather, first and foremost?
The weather today is cold. We took a little sharp turn this morning. My children, I've got two middle school aged boys who, if anybody out there who has middle school aged children knows that they are allergic to coats. And rather than wear a coat, though, they both wore thermal underwear. So that kind of shows just the dip in the temperature for you.
Well, that's one thing I don't miss down here in South Florida. I don't miss that at all. But what I do miss, and I said this on a previous podcast, I do miss down here Christmas when it's 70s and the 80s. It's something you never get used to. So I do miss that. And we're heading into the season where being in New York or the tri-state area, to me, the risk of overstating it, can be kind of a magical thing. But I digress. Kate, I'm not Henry Higgins exactly, but I detect an accent.
Yes. So I am English originally, born and raised in the northeast of England, north-ish. There's some debate about how north it is, a place called Lincolnshire, and moved to the States when I was a teenager with my family. And I've been here ever since, which is why my accent comes in and out, hovers sort of somewhere over the mid-Atlantic.
Oh, it does. Okay. It's funny. I've known people who were born and bred here, spent a small amount of time in the UK, and they come back with a highly suspicious England-tinged accent. So, yeah, it's kind of interesting that you still, between two stools, as it were, but I definitely hear maybe to my ears, I hear the UK or the English dominant side of it. In any case, getting to your work, much of it is focused on children and adolescents. So what prompted this focus? I'm curious.
It was actually more the focus on the criminal or the juvenile justice system, really, that drove it. I had always been interested in sort of mental health of people that were involved in the justice system. And I don't quite know why. I've just always had that interest in. But I think the focus for young people really emerged when I was as an undergraduate. I went to University of Michigan, and I was doing we have opportunity to do placements and rotations as part of our psychology degree. And I was working in a residential treatment center with young people and was just really moved by their experiences and their lives and kind of their experiences that had really shaped them and was probably driving some of their behaviors, in addition to the mental health challenges that many of them were facing and navigating. And for some reason, that was just where I focused and remained in the youth space ever since.
Does it help in any way in raising two middle school kids? Raising two middle-aged kids would be a very strange situation.
Something went wrong.
Something went wrong somewhere.
Yeah, if I'm still doing that. Yeah, yes and no. I think obviously I feel like there's, as my children move into that adolescent age where a lot of my work is focused, it definitely maybe brings it to life even more. I do a lot of work thinking about kind of the family system as well, not only just the juvenile justice system. And I definitely probably have more empathy for caregivers now as I'm navigating the same period myself.
When we spoke, we thought it'd be a good idea to provide listeners with context about the juvenile probation system. What are some of the common misconceptions?
So I think there's maybe some misconceptions about the system itself, and then the children that are within it. So the juvenile justice system, largely speaking, actually looks different all over the country. So we don't have a single sort of monolithic system that we can talk about. So it varies from state to state, which makes doing this work a little complicated and challenging. But overall, there are kind of three static components of the system. So there's the what we call community supervision. So as the name implies, it's the part of the system that is hopefully ideally supporting youth, but supervising youth as they live in the community. So they're at home, they're not in a locked facility. We have detention, which ideally should be for short stays, either pre or post the sentencing period or during the sentencing period. The court, and then we have what we call more long-term placement, which is following a disposition or youth has been sentenced, and those facilities are locked, typically locked facilities, and a youth is there for a longer period of time. So are these three components. But I think one of the points that's important to think about is that once a child is involved in the justice system, it can be very difficult for them to disentangle themselves. There's a lot of, I think we're changing now as the system evolves and progresses, but it can be very difficult for somebody once they're placed or in detention and come out to remain out of the system. There's a lot of hooks and snares that can bring them back in once they first make contact. So that's kind of like the system itself and the ways to think about it. And the community supervision portion, if you will, of the system is thankfully the largest. So that is where most youth that are justice involved, that is who you're dealing with. Is they're out in the community being supervised while they're living at home or with family in some capacity. But I think one of the biggest things we always sort of say here at the center is that youth in the justice system are mad or sad, they're not bad. And so really thinking about that there are experiences that these children have had that really sort of drive and shape some of their behaviors and the reasons why they may be sort of caught up in the justice system. But to think about that they've had these experiences that have make them sort of either sort of internalizing or they're expressing externally and sort of externalizing their behavior. But it's rare that you meet a child in the justice system that is just quote unquote bad, that there's no other reason for them to have done what they did other than they just to do it. And that really doesn't happen very often. And so I think that's an important point for people to think about when we're dealing with youth in the justice system.
So you established the three fundamental components, and you said it can vary from state to state, which can be a challenge. Can you give me an example of that, how it might differ from New York to, say, Florida?
I think it's sort of some of the ways in which the system works. So how you enter the system, right? In New York, for example, you come to probation to do an intake, and then probation then determines where you may go at that point, whether they're going to divert you and send you home, whether they're going to informally adjust you and sort of place the youth on supervision, but not send them to court, or they could send them directly to family court and, have them go through that process. In Florida, I believe everyone goes directly to a giant assessment center. So it isn't probation. It's, they're called, I think they're called JAGs, and I forget what it stands for. It's juvenile assessment, and I forget what the G stands for. But it's a giant assessment center, and that's where they determine whether or not, where a youth is going to go, and are they going to be detained straight away, or are they going to go home? So everything looks a little different. And then the ways in which the procedures and the kind of the bar that's required for a youth to be detained versus to go home differs from state to state, and that can also differ from jurisdiction to jurisdiction. So there's differences in the procedural aspects of the way in which a youth will move through the system.
You have collaborated with Chestnut staff on about a half dozen projects, is my understanding, much of which focus on linking juvenile or young adult detainees to behavioral health services across New York and Indiana. How did you start working with Chestnut?
Gosh, I want to say probably like 12 years ago, on a project something called JJ Trials, which was a large NIDA-funded, National Institute of Drug Abuse funded consortium study. So I think that there were 7 sites. New York was one of them. Chestnut was another site. And we were really focused on using implementation science strategies to better identify and link youth who are under community supervision to substance abuse, evidence-based substance abuse treatment. And so that is where I first collaborated with Dr. Mike Dennis, and became a giant fan. And just there's a lot of similarities in the work that we've done over time. And the work that we do primarily with Chestnut right now, the eConnect work, was a sort of the brainchild originally of Gail Wasserman, sort of in its earliest inception. And so Gail, Mike, and I sort of met with and to really figure out how we could bring, it was called Project Connect at that time, bring it into the 21st century in sort of improving assessment and using or screening and using digital platforms to further elevate the protocol and the program.
Yeah, you anticipated my next question, which is about eConnect screening tools, which were developed to identify suicide risk and behavioral health needs among youth in justice and behavioral health systems. First, how are they developed and how do they work?
eConnect is really, if you think about it, it's more of a total system. So it isn't just about screening for suicide risk and behavioral health problems, but really the critical components that come next, which is what happens when, as a probation officer, you give a youth a behavioral health screen and they identify or they self-identify that they're having these problems. What do you do about it then? And that really is the kind of the crux of eConnect, is providing very systematic and streamlined sort of next steps for how to navigate and get a youth into treatment based on the clinical need that they've identified. So we started the screening component. Uses the screens developed by Chestnut Health Systems, the GAIN short screen, and also the GAIN I, which is the larger full assessment. We use specific suicide items from that tool, and they are put together on a digital platform. Essentially, it's a web-based tool, and the way that it works is a youth is handed essentially a tablet, and they're told to complete the screen, self-report, and they endorse symptoms that they've been experiencing over the past year, and then they hand it back to the probation officer, and the system then scores the screen in real time and tells the probation officer the degree of risk that the youth has sort of presenting with, clinical risk. And we have 3 categories and then a below threshold. And the 3 categories are organized such that the class 1 or category 1 is the highest clinical need, and that is a youth that's endorsed suicidal thoughts and behaviors that are very recent, within the past week or the past month. And that indicates a youth with a level of clinical need that ideally that youth should have a same-day clinical assessment to make sure that they're either safe to go home with some safety planning in place and a future outpatient appointment, or maybe actually know that youth needs a higher level of care and they should either go to the ER or to an inpatient unit, depending what's available. And so the probation officer recognizes that. Then there's a class 2, which is those youth that they're in crisis, but it's not acute. So maybe they're endorsing suicide thoughts and behaviors that have been going on for the past month to 3 months. And there's also mental health and substance use that's playing a role as well for those youth. And so it directs the screen would then say this is a class 2 and would direct the probation officer to get a referral and a treatment appointment on the books within 72 hours or 3 business days. And then class 3 is a youth that just has behavioral health problems, and just a standard behavioral health referral. So there's no crisis, there's no sort of time requirement on that referral, but the youth should still be linked to care. So it directs the probation officer to know sort of how to respond, and then also to for each location that eConnect is delivered, we have a whole process in place where before eConnect is even rolled out, we determine these referral pathways. So for each class, we determine which provider in that local community is going to be the responding provider, crisis response provider for class 1 or 2, and then we have probably a cadre of providers available for the class 3 youth. And we bring everybody to the table and we talk about it, and we get very specific details as to, if you're a class 1 provider, are you going to be able to come on site? Is this a telephone assessment? If they need to go to the ER, who's organizing transport? Can you do that? Do we need to call the local law enforcement to have them bring the youth to the ER? Can parents do it? The same for the class 2s, which is, can you guarantee that if we call, you can get this youth in within 3 days? Because this is a kid who can go home, but probably shouldn't be left, without a clinician assessing them. And so that work happens about 2 months before we go live in any given site. And it's all programmed into the tool so that once those decisions and agreements have been made, when a class 2 pops up, Officer Kate knows that she has to send the child over to such and such behavioral health agency, and they will agree to see that and give them a 3-day appointment, which can be difficult to do, especially now in
Sure.
the context of behavioral health crisis, or provider crisis.
Sure. As a young person once myself, I know that self-awareness is not exactly a well-developed skill, which begs the question, when you're asking young people to self-report, what are the challenges inherent in that? Because I'm assuming there are some significant challenges in that.
There are. So we have consistently, we've done this in New York now for about 7 years. We're also doing it in Indiana, and I haven't quite looked at those data yet. It's a much newer project, but in New York, we have consistently identified rates of behavioral health need around 40%, even during COVID. So just this consistent rate. So it suggests that the tool is able to identify pretty well the sort of the experiences that youth are having. Yeah, sure, there's going to be some over-reporting and under-reporting, of course, in either direction, but on average, we're having this really consistent rate of response. And youth do report. I mean, we are identifying youth who are experiencing crisis. On average, in New York, right now we're in 12 counties, but when we were doing the main trial to test eConnect to see if it worked, we averaged about 1 youth a month that identified suicidal thoughts, behaviors, and on average, and also youth were endorsing substance use, even if it had nothing to do with the reason why they were there. So I think that one of the things that we do know in general is that youth are better reporters of their substance use, of their internalizing symptoms. So there's things like anxiety and depression, things that likely, more frequently happen on the inside that may be not as observable. And also their suicide sort of risk, their thoughts and behaviors. They're much better self-reporters than parents. Parents frequently get it wrong. And so youth report, honestly, is the one of the best ways to go.
I mean, the parents of those youth.
Yes, the parents of youth. I mean, I think that I read a really awful statistic. I can't remember what it is, but there is of youth of any adolescent in this country that unfortunately committed suicide. The response of parents to say that they just had absolutely no idea is above 50%. I mean, really just had no idea that their child was struggling.
I'm going to ask this, and if you don't have a ready answer to it, because it may actually be outside the scope of your work, how is the accuracy of self-reporting among this cohort different, either better or worse, than older cohorts, people in their 30s, their 40s?
I don't know. I don't know that anyone's really looked at that. And the reason being is that your experiences, people that have done sort of longitudinal studies of behavioral health problems, right? Or even if you've done cohort studies, show that sort of we see behavioral health problems have their onset in adolescence and young adulthood, and then either, depending on the type of mental health problem we're talking about, either kind of go down and sort of plateau or just disappear entirely over time. And so it's kind of hard to really look at like the validity and reliability of that over time, just given that it's cyclical in its nature. And also too, adolescent mental health problems look different than, I'm just thinking about, for example, bipolar disorder. Bipolar disorder in an adolescent presents very differently than it does in somebody who's in their 20s or their 30s. It's much more, I don't know, I want to use the word disorganized, but the disease does not look, it doesn't have the clear cycles. Oftentimes it's taken for ADHD. It's not as clearly, nicely defined as sometimes you get when you're older, and you get these very clear, obvious highs and lows. And it doesn't always appear that way in adolescence. It's just because it's the disorder is emerging, right? And it's kind of coming into itself. So measurement is difficult when things look a little differently. So comparing measurement in that way.
Yeah. Okay. eConnect, you say it's been rolled out in New York, in Indiana, across the length and breadth of both states?
No. So in New York, we initially did it in 10 counties, the initial trial, and now we're slowly but surely expanding. So we've expanded to 2 more, and obviously we have an eye on kind of expanding it further in New York State. With funding is always the issue there. And then in Indiana, the question there was, is eConnect, I mean, ostensibly, there were sort of 2 questions. Is eConnect really a tool for New York? Because remember, I said that sort of like juvenile justice systems vary, and as do behavioral health systems, right? The way in which states and counties function differ. So is eConnect really a New York sort of centric and only tool that can be used in New York system? Or can we take it somewhere else, and with some minor modifications, does it work just as well? And then also too, we want to be able to thinking about like scaling up. What is required to scale up something like eConnect? So if we wanted to take it beyond the 10 counties in New York, what is an efficient way? What's required? Sort of boots on the ground, as well as at sort of higher up sort of systems, state systems, county systems level, what's required for eConnect to be implemented. So that's what we're doing. We were just in 9 counties.
Okay. Because that was going to be my next question. What are the plans for rolling this out, perhaps even beyond New York, beyond Indiana, and how does this scale? Are you adding other functionality, for instance, I don't know, AI or any other components? Is there anything on the horizon that you could share with us?
We are so we have sort of what we called eConnect 1.0, the original version of the tool, of the system. Yes, we're always thinking about the ways in which we can utilize the system to either gather more information, to make it more effective, to integrate with other like justice management information systems so that it's kind of more seamless and more cohesive, changing or adding additional questions, trauma-related questions, more, do a deeper dive with trauma. So these are all things that we're sort of thinking about how to do. And then they're really, but just generally speaking, how to scale up a system that really requires that it's because it's tailored to each local, community that it's rolled out in. Really, so really, how do you do that? How do you do that in an effective way where it doesn't require me to be on the phone 24 hours a day talking to people?
Yes.
So that's kind of what we're trying to figure out in Indiana. What are the most, can we have folks that we almost can deputize to do the work in these locations where we don't have local knowledge, right? In New York, when we did it, I've been working in New York for many years, and so I had a lot of partnerships, and I already knew a lot of the players that were going to be involved, and so that went a long way. But in Indiana, didn't have that knowledge, and so really trying to figure out, do we need folks that have that on the ground knowledge that can sort of be that middleman, as it were, between us and probation and behavioral health. So that's kind of what we're testing right now.
Pardon what may appear to be a little bit of a digression, but it occurs to me as we're talking about this. My daughter, she's going into her, I think, 3rd year of medical school. Actually, she is going into her third. I should know that, right? Not I think. when I'm paying a lot of these bills, I should know this. In any case, she's doing some practice exams for the STEP exam, which, as you know, determines or largely determines where she's going to do her internship. And she has taken about, oh, I don't know, 6, 7, 8 practice exams. And, she's been scoring in a certain way. Then all of a sudden, she got a lower score and she was really concerned. So she got upset and she calls me up. We had a conversation about it. And then about a day or so later, I asked, how you doing? Are you back on your feet? Is everything okay? She goes, yes, thanks to you, thanks to Jesse, my boyfriend, thanks to her therapist. Last but not least, ChatGPT. I said, not necessarily in that order. She goes, Dad, with all due respect, it was actually ChatGPT who was really, or who, that was really helpful. And she walked me through how, in a very specific way, it was very helpful, more or less, not reassuring her so much, but sort of reinforcing some of her strategies for taking the test, getting mentally prepared to take the test. I found that kind of fascinating.
So I think that where AI from a therapeutic beneficial perspective, I think is probably, the new frontier that we're trying to figure out how to use safely. I think that there's, I'm sure you've heard about the AI companions that turn sideways pretty quickly, and an individual is a child, it was a teenager, I think there's a couple of instances
Yeah.
this has happened. They're essentially struggling by themselves at that point, and the AI companion doesn't help, actually hinders. So I think that there's definitely a role for AI in being sort of an adjunct to more human delivered care and prevention. I think we're just trying to figure out what's the way in which we can do that, most safely and in a way where the guardrails remain in place, because I think right now what we're seeing is we put these guardrails in place and AI just goes right around it. And
Right.
right. And so there's for folks that are interested, there was a really good article in the Atlantic maybe 2 months ago, just about that very thing, about kind of the this AI program had been, touted for teens. It was supposedly safe, and that the rider obviously is an adult, and they were able to circumnavigate relatively easy and relatively quickly the safeguards that were in place.
Yeah, no, it's a fascinating conversation. I try not to introduce this into all these podcasts, but it's irresistible
I know.
sometimes. It's such a big and interesting issue. Last question, Kate. Can you give us a sneak preview of what's in store for 2026? Any new studies, anything else in the works you care to share with us?
So with respect to eConnect, we're really looking at so two things we're thinking about. One is right now eConnect was developed and is being delivered with adolescents. And there's a caregiver in the mix. And in many of the points of sort of like, what would be the word, where probation is able to screen youth and identify suicide and behavioral health risk. Parents are in place. They're there. They have to be there because it's part of an initial interview. But what happens if we do it with young adults who are, as a cohort, actually are not doing very well compared to, say, adolescents from a behavioral health perspective? Rates of suicide is still incredibly high. Sort of comorbid opioid, substance abuse is really high, particularly for justice involved individuals who we know as well really lose sort of some of these familial and social supports as they age. And so what are the adaptations that are required for eConnect to be delivered with that particular age group? Where there is not necessarily, it certainly does not have to be an adult in the mix, and there may very well not be. How do we leverage that? Where's support? Is it AI? Is it where our thoughts are peers, near peers that could come and connect with that young person? But then also too, another part is just really thinking about right now, eConnect is primarily sort of a SAFO systems level intervention where we train probation officers and we get local behavioral health providers and agencies to work more effectively together. We don't directly work with the families. So that is, we kind of work indirectly with the families through the probation officer who's delivering the tool. We train them. But are there things in which we can expand with the eConnect system to do a better job connecting with families and further supporting that connection to treatment? We saw we had really nice results with eConnect when we ran the trial, sort of double the rate of referral once the youth had been identified with treatment, and almost triple the rate of treatment initiation, simply by having these very clear pathways and sort of this communication and cross collaboration of checking in when somebody, whether or not somebody got to treatment. It was great, but there was still probably, we missed, 30% of the youth that had a behavioral health need still didn't get to care. It was still a lot higher than when we, before eConnect, but that still, for me, I'm feeling like that's 30% more improvement that we can do. So really thinking about, is there a familial element now to eConnect that we really want to incorporate so that we can provide additional support to those families that are still struggling to get to treatment and what might be going on there. So that's kind of where we're heading next.
Excellent. Very, very interesting. I'm going to have you back to discuss that when you have something to report. So I'll be checking in a little bit down the road, Kate. Really do appreciate spending this time. It's a great conversation. Much appreciated.
Thanks. Oh, you know what? I just thought too, the Florida, it's not a G, it's a C. It's a center, the Juvenile Assessment Center. It's a JAC, not a JAG.
Oh, okay.
That. So yes, you don't want to keep the Gulag piece in.
Okay. All right. Well, no, that was good. I appreciate at the 11th hour salvaging that. Anyway, Kate, really do appreciate it. Really great conversation. Again, I'm going to have you back. Today, I spoke with Dr. Katherine Elkington, professor of medical psychology in psychiatry at Columbia University and a research scientist at the New York Psychiatric Institute. She joined me today from her HQ in New York City. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.